Morning, this is Dr. John Bennett, broadcasting from Miami Beach, the home of Neurosurgical TV. We have a talk today by Dr. Sharma Karan, a neurosurgeon from India, New Delhi, I believe. He'll talk about that. But first, let's introduce the panelists. Good day, Marco.
Hello, everybody. Nice to meet you again. My name is Marco Meroni. I'm a consultant neurosurgeon in Gravedona, North Italy.
Yeah, and the future head of Neurosurgery.tv.
Neurochirurgia, yeah.
Neurosurgery. Okay, Dr. Kabulo, are you there?
Yes, my name is Kabulo from Congo, currently final year neurosurgery resident at the University of Zimbabwe.
Okay, well, you're always welcome, Dr. Kabulo. Chandra, could you please introduce yourself?
Hello, everybody. I'm Chandra. I'm from India. I was in the UK for some time.
Okay.
I'm on a break now in India, neurosurgeon.
Oh, what part of India?
Madras, South.
Okay, welcome. Welcome.
Thanks.
Okay, Karam, it's all yours.
Thank you very much. So now the video is on now.
Yeah, yes. You need to start. Could you introduce yourself, please, and tell us where you work or etc.?
Okay. My name is Professor Dr. Karanchand Sharma. I'm 63-year-old. For the last 14 years, I was the professor and head of neurosurgery department at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Now, since I'm 63, I've taken a voluntary retirement to write books and also for the neurosurgery education. And of course, I will have my outpatient clinic where I will continue to see the patients. And I have been trained in 1986 from All India Institute of Medical Sciences. And before that, I did my MS post-graduation from PGI Chandigarh and MBBS from Medical College in Shimla. So I got what I wanted. I want to take a very hard subject so that I can contribute something to the field of neurosurgery. So I have now finished my professor career and I now concentrate on my writings. Is that Bennett okay? Hello?
Yes, on to your presentation, please.
Okay, sir. Now,
okay, let's see if we can get this screen sharing this time.
Yeah, it's okay.
It's okay. It's informal. We'll get it. You're presenting from a smartphone. That's okay.
I'm going to the photos and the camera and the important photos.
We're ready to roll, Karam.
Here I am. Now, this was very important.
Very good. Okay. Very good. Okay.
This was very important event in my life. In January 1991, I served as a United Nations volunteer in Apia, and the country was that time called as Western Samoa. Now it is called Samoa only. And these are all the friends who were there from India, Bangladesh, Nepal, and Burma, and they have come to see us off at the airport on 22nd of November 1992. This is an artery forceps, and it has a lateral curve, and you see it was without teeth attached to the scalp. When you cut the scalp, that was called a dandy forceps, referring to Walter Dandy, who lived till 1946 at 60 years of age, and all through his career, he was at Johns Hopkins. And not only these instruments, but he innovated so many things. And we have a Walter Dandy syndrome, and also other important surgeries like clipping of the aneurysm in 1935, and then standardizing how to open the skull. And he taught a lot of medical students. He was quite junior to Cushing, 17 years, but Cushing, and he had a very big rivalry, and both of them, they excelled in developing the neurosurgery and safe neurosurgery there. So going on his lead, I read his history and everything. There are some things which only surgeons can make. Others can't make it because the experience is only with neurosurgeon. He knows what is needed and what is not needed. Uh, I go to the other images. This has a 3x2 teeth. Okay, share. Then I go to photos. And photos that these. Okay, right. Now, the interpretation of the CT scan, how we should do it, and how I have added a new knowledge to the.
Okay, we're not seeing the screen share.
Yeah, I'm on the screen. I'm just coming.
Okay,
Yeah.
we don't see it.
I'm just coming.
Right.
Okay, just a second, sir. Now, here am I. You can see that. Okay, yeah. You can see all of you. Can you see it, please?
Yes, we can see pictures, but no equipment.
Yeah, that is my foundation.
Okay.
When I was college,
Okay.
I was literary secretary of the medical college, and therefore I had to read all the general knowledge books. Then I had to organize contests between the classes, like for declamation contest, for debate, then the annual function. On the right hand side is the director of PG at that time, Dr. Neki, who was a famous psychiatrist. And on my right hand, you can see that is Professor A.N. Mehrotra, who was the principal that time. So this took quite a lot of effort to organize the whole thing and give a new meaning to my life, that something new should be done. I'm just coming back with new one. Okay. Now, all of you see this instrument?
Yes.
That is the one I insist that all my postgraduates, when they join neurosurgery, they should have that in their bag. Apart from hammer, stethoscope, then wool, pinch, and test tube for testing the temperature, they should be identified, the neurosurgeon, for taking the history of the patient in detail and examining not only neurological, but we should also pick up that there is a hypertension, diabetes, or some other thing. And many times during my career, I needed this. This is a twist drill, and you operated by hand, because if you are electrical one, then you have to have that all battery charged up, but this can be done in 2 minutes on patient's head, and you can tap the lateral ventricles anywhere, right from the frontal region, classical, that is you are just in front of the coronal suture and 2 centimeters away from midline, and so many other places we can tap it. So if you have this, you just keep the length of this according to a thickness of the skull. Lot of drill bit should not be exposed. And when you do it, you move it clockwise, not anti-clockwise. And you ensure that you have cut the outer table, the inner table, and also dura with this. If you don't cut the dura with this, and what happens is when you are introducing the brain needle, it will strip the dura off the brain, and that can later lead into extradural hematoma or intracerebral hematoma, which one should avoid. Now, there are various diameters of this drill. You should have that much hole. The diameter should be such that you can pass a compatible brain needle. The brain needle is quite different from disposable needles and other needles because it does not have opening at the end. It has a side opening just behind the tip of the drill. and you go towards the midline, but then you must think about the anatomy. You don't run into superior sagittal sinus. And if you do that, then more damage will be produced than the other thing. So this is the first thing I teach my residents who are already general surgeons and they have qualified their MS. You just inject a local, wait for 2-3 minutes, give a stab incision, and then put this. Now, in all the places and the corners of the world, you don't need a EVD or external ventricular drainage set. If you do that, you add a lot of cost to the operation of the patient, and patient ultimately uh, becomes poor after you asked him to give all the money. Neurosurgery, you already know, is very expensive, and in the most corners of the world, because of reason of not acquiring instruments are too expensive instruments. This is a very simple thing. And when you spend a lot of time, like 3 decades, 4 decades in neurosurgery, you will be able to appreciate that you have saved many, many lives just because of that, by doing a twist drill hole and passing a brain needle and tapping the ventricle. Now, while you are tapping the ventricle, you don't allow the free flow of the fluid. If you allow that, then the pressure will be so less that again you will have bleed in the intracranium. So the external ventricular, I usually use a infant feeding tube, 7 number or 8 number, and I thread that to the lateral ventricle and then bring it out, fix it in the scalp, and after that connect it to a sterile bag, which is usually a urine bag, which is available everywhere. So infant feeding tube and that one, the bag, they just cost you less than 100 rupees. So a very expensive procedure can be reduced to this twist drill. And I'll concentrate on this because I know this is the most important thing, that how a neurosurgeon will differ from a general surgeon, a general physician, or others. Now, after you have put a external ventricular drainage, you should not keep it below the head level. If you try to keep it below the head level, too much CSF will be drained and you will have more complications. So it should be tapped, and if you have to aspirate, just use 2 cc syringe, because if you take 5 cc syringe or 10 cc syringe or 50 cc syringe, the lot of vacuum effect will occur and you can suck the brain tissue rather than the ventricles, tapping the ventricles. Now, when you're passing a needle, brain needle to the brain to tap this, you should, what you should do is that you should have that fine sensation in your head that now you are past the cerebral cortex, you are in the white matter, and now I have reached the ventricle. Now, I will just correlate it to one thing, that lot of patients of neurosurgery just before the surgery need this temporary drainage. You can avoid placing a ventriculoperitoneal shunt with its complications like obstruction, like infection, like extrusion, because it's after all a foreign material made of silastic. There's quite a heavy valve, and then you have to put it in the abdomen. No shunt surgery as such should be taken very lightly. But if it is necessary, very necessary, like in infants 6 months of old, where you can't do endoscopic ventriculostomy, you should do that. And you can expect some of the congenital hydrocephalus patients to go on and become normal individuals, because the head is enlarged, therefore the surface area of the brain is quite a bit. It might be as good as your own brain. And so large heads are not necessarily hydrocephalus heads. They are actually because of many other conditions, like storage disease is one of them. then you have the subdural effusion, then you have hydrocephalus. So once the switches close, like the posterior fontanella will close at the 6 months of age, by 6 months of age, and the anterior fontanella will close at the
Okay,
1.5.
excuse me, Karam, you're still on the first image. You want to stay there on the first image, or
Look, I'm going to talk in
yeah, you're
detail.
still on the first image.
Even if I talk a little bit, I want to talk whole procedure to a residents to realize the significance of that, please.
Oh, okay.
And-
So you want to be on the first image, right?
Yeah, I know. I'm
Oh,
deliberate.
okay. I thought you didn't know what image you were on. Okay, I'm sorry to interrupt.
Oh, okay, sir. Right, doesn't matter. So, twistal craniostomy, described by William Cohn, who was professor and head of neurosurgery at MNI, famous MNI, where the other neurosurgeon was chief of that institute, and all of you know his name. Now, you know William Cohn because of one thing, that he introduced this twistal craniostomy, and he also made Cohn's traction for fracture of cervical spine to stabilize them, and many other which he has not published, but he is remembered as a great teacher. So this is about twistal craniostomy, which plays a very important role in life, not only for tapping the ventricle, but it is very essential to tap the brain abscess also. Well, if you have to tap a brain abscess, you should localize it by craniometry. Now, what is craniometry? Craniometry is not what you say a very complicated thing. For this, you just need a tape, and you need that foot rule, how much 1 centimeter, 2 centimeter is. So if you mark the distance from nasion to the inium, and then divide this into 1/3 anterior, 2/3, it will consistently tell you that here is the corneal switcher. And your CT scan interpretation should be such that you should be measuring by the CT scan given scale, and to transmit to a foot rule, that is the real one. So the CT or MRI scale might look very small. So you should go according to that. So this tapping of abscess, ventricle, then tapping in situation like a patient presenting in emergency with arachnoid cyst, this is what is required. So I'm going to share then.
Okay.
Yeah.
Okay, I don't know if you want to do all 15 instruments. I don't think we'll have the time.
Not all of them.
Why don't you just go over a couple then?
Not all of them today.
Yeah, we don't have time. We don't have time. So, yeah, if you could present a couple of more, that would be great.
I will show their pictures just now.
Yeah, I guess we can't do all 15, obviously. So
Yeah,
let's do a couple today. We'll do some more later.
already advertised that picture, and you know that what are my instruments, and I have got them right now with me here. So
Why don't we do five? Why don't we do 5 today? Okay, we can always do another time. Can we do 5 today? 4 more today, please.
Sir Bennett, sir, there's no point if I just enumerate and don't tell their use.
Oh, you can't do 4 more?
This is a neurosurgery which has been learned in 36 years. Not one day.
Yeah, I know, but we can't do all 15 today. I don't think we're going to have the time.
I have standardized it. Now, here is the another.
Yeah.
Yeah, can you all see?
Yes.
Nobody had the chisels of this type earlier than that. This had purely come because of my thinking. Now, in my method of craniotomy, either there is a small refined with Duragard, or we have various diameters right up to 5.25 centimeter. So up to 5 centimeter, if you need a craniotomy, that refined with adjustable Duragard is very, very good. But if you need a larger exposure, then I have another method that is called Karamchand method of craniotomy, where you just need minimal instruments. You need a sharp chisel, a little hammer, and you need a drill which you can hang at the IB stand, and is locally available everywhere. And you just sterilize the arm of that with, say, uh, hydrogen peroxide sterilizer or something like that, so that the whole procedure becomes sterile. You don't have any chance of introducing the infection. Now, my concept is that what was described in 1889 by Wilhelm Wagner to how to do a craniotomy. Now, he had copied a technique from his friend whose name was Julius Wolff, who was uh, doing craniotomy in animals. So what he did is that he raised a true osteoplastic flap where you cut the skin along with the pericranium and make it a flap like a H-shaped or something, inverted U-shaped. Now the base of the flap should always be larger than the height of the flap. If you follow this one principle, you will not be doing any cosmetic damage to your patient. Now, what part we lacked was that Cushing, Dandy, Frazier, and all of them, they blindly copied the technique of burr-hole-based craniotomy. And if you realize that you have a very large instrument, Hudson brace, and with Hudson brace, you're putting your body behind that, and you are cutting, drilling at 90 degrees to the skull. And then you have to suddenly realize that now you have reached the dura, because that way there is a resistance. Now in my career, I have seen many people pushing the perforator into brain. You have to suddenly change, accelerate to deaccelerate very fast. So if you have not done that in your career, you are not telling the truth. Well, this happens to everyone, and the inadvertent damage which you produce with that is too much for the patient. Now, you must have seen my Refine, which has a adjustable Dura guard. And with that Dura guard, what you can do is that there are two rings on the outer surface of the Refine. Now, you rotate, and again cut with 90 degree. And you first adjust those rings up or down where you want to put it, how much cutting length you want. And that safety, you can actually measure it on the CT scan and see how much is the skull thickness. And there is a scale on that Refine which says that 2 millimeter, 3 millimeter, 4 millimeter, something like that. So to match that Refine, I have invented these also. Like you have taken a drill and drilled out along the circumference, you can under vision see that I've cut the outer table, then the diploid, and then the inner table. So you leave a very thin part of the inner table all around. You get that feeling with drill because you are pushing, you are not pulling. When you are pulling, the force can never be even, because you know that how the spasticity, rigidity, there is a clasp knife sign. So similarly, here also you have that. Now, even if you are amateur and you are not used to it, then the problem will be that you cannot push inside. And if you have left a small part of the inner table, you can use these chisels with the guard. Now you can see those guards put at the dura protectors, and mainly this I use for the posterior fossa craniotomy. So I have never used a craniectomy for last many years in posterior fossa lesion. And let me admit to you that doing a craniotomy in posterior fossa is much easier than doing a craniectomy. And if I introduce the bayonet chisel, the remaining part of the interval, you can very nicely cut it. So when the patient comes back, you see that as if his head has never been operated. It looks like a normal, and the bone fusion rate with this method is very high. Now you see these chisels, you cannot push beyond a certain length. So you cannot hammer into the brain this, even if you are an athlete or some very powerful man, you just can't do it. And there is always no change in the position of the head when you hammer this tangentially. You don't go at 90 degree. If you go at 90 degree, you will be right into brain. So you try to go tangentially, and that is other advantage also, that there will be a lot of overlapping of the bone flap and the remaining bone, and there will be no defect left. If you are worried about extradural prolapse, then what you should do is put small drill holes in the bone and put a drain outside it, over the bone. It unites very nicely, and you must have seen that in aneurysm surgeries, when the patient comes to you, you have already produced a big defect behind the eyebrow. And when the patient becomes older, then you will see that skin goes in, and from a distance you can make out this head has been already operated. So never put a scar on the forehead of the patient. For example, you want to do a right frontal craniotomy. And what you should do is that you should go across the midline behind the hairline. And then you can pull down the flap right up to eyebrow without taking the incision up to the this thing, without taking the incision into the visible forehead, which does not have hair. That gives patient a lot of confidence, because even if you are walking, you see other person in the bus, you will see that this head has been operated at 4-5 places. You will see those bar holes, and I'm telling you the real teeth, they don't look nice for your work. If the plastic surgeon does not use tooth forceps for the skin, pays that much respect to close layer by layer, then we are the microscopic surgeons. If we are microscopic surgeons, why we should give the wound closure to the junior most man? Should never give it, and we should always do the anatomical layer-wise closure. And after that, you will see the scalp is very vascular. You rarely get any infection in the scalp because of this increased vascularity. Now, if you have messed up everything and you have not closed the temporalis fascia even, then you will see when the patient is chewing, the muscle will be bulging from the temporal region, and the family also notices, the patient also notices, although you think these are very small things. But for a given patient, these are very big things, that how one appears at the to the others. A similar thing, people have put endoscopes, they have done minimally invasive in spine. It is not minimally invasive, that is maximally invasive. It is better to cut back in the fashion, and then you go on the either side rather than contusing the muscles and everything by increasing the diameter of your whole lateral bit, and forcibly applying a retractor there. That produces fibrosis. So you should not be doing that also. I go to other mates.
Okay, we have to wrap up in 15 minutes, Karam. So.
Oh yeah, I will do that. I don't worry.
Okay, yeah, we have 15 minutes because I have another presentation.
Yes.
If you don't mind.
Thank you very much, and
Sure.
that is
Okay, you got 15 more minutes. You got 15 more minutes.
Okay, sir. Thank you.
Good.
Now I will go back. Now look at this image. It is not about all my instruments or what is my contribution. It is about the minor changes I have made or thought over the years, from a medical student to a fully qualified neurosurgeon. Now, all of this, you are seeing the picture of this patient. Now, what you appreciate here is that the temporal artery has become very tortuous and visible. Now, why it has become tortuous? Why the other arteries have become tortuous in the patients is because whole of life, the length of the artery increases. So there is an angiogenesis factor till it is prohibited by body's immunity check. And if it has to travel the same distance, it has to become wavy. Now, in children, I operated some aneurysm. The arteries are very, very straight, and they are never curvy like this. That is why operating an aneurysm in a child is much easier than in adults, where you see a lot of changes. A straight artery becomes very, very curvy, and veins accompanying also enlarge in life, and this produces the obstruction. Now, pushing some fluid in a straight artery is very, very easy. So the child will get a good blood supply to all his hands, feet, brain, etc. But once these wavy things occur, then the heart has to work more harder to keep the blood supply to the distal parts of the body, and then you get a hypertension. That is the basic etiology of what you call idiopathic hypertension. Not only that, that there is a vasculitis at various segments of the artery, which is responsible for platelet aggregation and plaque formation. So when you are operating as a neurosurgeon, you should be very, very careful that you don't get rid of superficial temporal artery. Two things will happen if you do that. The wound healing will become poorer. One. And two, you will have no chance to do a superficial temporal artery to middle cerebral anastomosis later in the life if the patient needs that. So the superficial temporal artery should also be respected as much as anterior cerebral artery or the middle cerebral artery. If you don't carelessly open this, divide the muscles, temporalis, the fascia, you go right up to zygomatic arch, and from that, if you separate the muscle, temporal muscle, you have made the life of some person a miserable life. Immediately post-op, he will have to go hungry because as he chews, his pain is apparent to everyone. So if we are doing a neurosurgery, then we do not want to produce a deficit which was not there before the surgery. So you have to be that careful that your cosmetic part is as good as it is. Now, if you need a limited craniotomy, like you have for the pulp brain and contusions, temporal contusions, frontal contusions, and other conditions like extradural hematoma you have there, or if you want to a limited excision of the hippocampus, then a small craniotomy with 5 centimeters fine is more than adequate, because you are guided to the structure by the bony landmarks. You know where to put the craniotomy and how to go. If there is a temporal pathology, you don't want to go into the middle temporal gyrus or the superior temporal gyrus. And that boundary is defined by the vein of Labbe. As you see, preserving the vein of Labbe is a main work of neurosurgeons, whatever surgery you are doing. So most of the seniors will give this craniotomy to the junior most colleague, and they will just take off the gloves, and whatever switches they use, they will not mind it. But that is a very wrong practice, that this part should be done a very good surgeon who knows something about plastic surgeon and can bring the wound edges very nicely together. So This is one of the relative of the patient who had just came to see his relative who had developed a venous infarct about 2 weeks back. And I just happened to photograph his temporal artery just to demonstrate that how perby it becomes and how it has not received the attention which it should have. If you see the cardiothoracic surgeons, you will see they don't bother about internal memory artery. And they don't bother about internal memory artery, then the result is that wound healing of the sternum suffers. How I wish, like us neurosurgeons, they do a osteoplastic thoracotomy, because then they can raise a flap and there is no need to cut the sternum. But it is for them what to follow. They use loops for microanastomosis, but a neurosurgeon should never be satisfied with loops. Neurosurgeon always, right from the day first in neurosurgery, should use a microscope. And you achieve a binocular vision from the microscope with practice. It does not come on the first day. But practice that, you can buy the binoculars or telescopes, then try to see one image, with both eyes, shut one, shut other, until you adjust the interpupillary distance, and then see that the image is one. So those who have telescopes, they don't find microscope very good. The other thing with microscope is that there is a very good light, which you cannot achieve with headlight, loops, etc. So you have to be very careful about that part also, especially in children, small children. The flap should be made by a senior most doctor and should not lose more than 2-3 cc of the blood. If you lose more, then the child will go into hypovolemia and will not tolerate the surgery. I have seen many patients with others who were operated for a very benign condition like craniosynostosis or growing skull fracture, and in the middle of the operation, the hypotension occurs and arrest occurs. So there are some things which we should make common, that what should be the curriculum of the residents, what we should teach, different from the plastic surgeon, different from GI surgeon, or different from the urological surgeons. So that comes with training. So I moved from this image, this was used for demonstration how the hypertension occurs and how the idiopathic is just labeled as idiopathic, although that always has a cause. 20% cases of atherosclerosis are of viral origin. These are new knowledges. These are very new knowledges which define how the Indian patient will get a coronary artery disease earlier than the patient in the Europe. And that is attributed to malnutrition. And the time the heart develops, there is a deficiency of the nutrition, and the premier development occurs in the brain at the cost of the heart. So the number of cells in the heart which were to be formed are not good. So the fibers will hypertrophy, the cell number will not increase. So at 30, 40 years of age, patient will start getting myocardial infarction. And if they have myocardial infarction, you will see most of them associated carotid disease. So most of our patients with ischemia, just check.
Okay, very good. Okay, that's all the time we have today. We can certainly schedule other talks.
Yes.
And first, let me ask. We had a panelist. He's gone, but that's okay. We'll just have to schedule more talks because you seem to have a lot of things you've done in neurosurgery, and we got to adequately cover it. I think we're going to need more presentations. You can't do everything in one, correct?
Thank you. If I want to explain, I will explain in detail how I thought about it and why I did it.
Yeah, okay,
So-
we can do that in the next one. Okay?
Yeah, will do. Just leave me till 16th. I'm going to Moscow.
Okay, well, okay, thank you very much, and we'll schedule another talk. We'd like to hear more about your equipment.
Yes.
Maybe go over piece by piece, because
Oh,
now
yes.
are this equipment's being used right now by residents in the world?
Oh, yeah, residents are
It's
very
being
important.
used, that particular device there, because I'm not a neurosurgeon. That equipment's being used today. Oh, I guess we're having some audio quality. Okay, we'll wrap this up. Okay, thank you very much, and I'll send you the recording, okay?
Thank you, Bennett. I'm highly obliged to you.
Okay, thank you. Okay, and we'll keep in touch to do the next presentation.